fantastic event, this. This is our third discussion meeting of this year. The other two were online, but we have another face-to-face meeting in the RSS conference in Aberdeen coming up in September. And then we're hoping to have two other discussion meetings in the year, which is before the end of the year, which is great. So this is the second of a batch of papers that we had for the statistical aspects of Covid-19, which was a call-out that we did. And the first three papers were presented at the RSS conference in Manchester last year, and it's a great pleasure to have two more papers presented this time. So I'm Shirley Coleman, and Chair of Discussion Meetings. This is Adam Sikolski, the Secretary. So it's a great pleasure to organise this meeting. Now these things are sort of choreographed, so we have strict times on everything. So 25 minutes for each of the papers, followed by 10 minutes of a proposer of a vote of thanks, 10 minutes of a seconder of the vote of thanks. Then we have some contributions from the floor, discussion contributions. Each of them can be presented for 5 minutes. But then it's a discussion meeting, so it's open to anyone else to say anything they want, and that would be limited to 5 minutes again. Because we want to invite people that we haven't heard from to contribute, please give your name and affiliation so that we can get in touch with you, and you can write up to about 400 words that will be included in the application, so that would be very good. After those contributions, we then invite the authors of the two papers to respond, if they wish to, and I hope you will, a maximum of 10 minutes each, so to the questions that you've had or things that have been raised. Just to say, there's no fire alarm expected. You dash out of there or there and meet in the corner if there is a fire alarm. We're going to be filming the event, so that it can go onto the RSS YouTube channel. So if anyone does want to be included, please tell us after, and then we can block you out or something. After we've had the meeting, we can have a wine reception, so we have wine and water, which will be in here again, and we can carry on the discussion, and then we will close by 6:30. So we're aiming to do this first part by 6 o'clock. So I think without more ado, I think I've covered everything. It's my great pleasure to welcome the first paper, and I'll just read it out so I get it right. It's the Bayesian semi-mechanistic modelling of Covid-19, identifiability, sensitivity and policy implications. Both of these papers will be published in the journal of RSS Series A, which is great, along with the discussions. This paper is being presented by two of these 6 authors, Samir Bhatt and Axel Gandhi. Co-authors Neil Ferguson and Seth Platzman are both here, and so we can pick their brains as well. So I'd like to invite Samir to come up and start proceedings, please. Thank you.
So, semi-mechanistic modelling of COVID-19 with renewal equations. So this is going to be a double talk with Axel and I, and we've got a lot to get through, so I'll just hammer on with it. So, first thing is, why the renewal equation? Well, renewal equation has been around for a very long time. It was first, used in earnest in applied research by Lochter in the 20s. And of course, was expounded, its statistical properties were expounded by Willy Feller in 1941 in his seminal work. But the primary use of the renewal equation in infectious disease modeling actually was introduced by Christoph Fraser in his great paper in PLOS ONE, where he used epidemiological arguments about an infection process, which then resulted in the renewal equation. Now, from a stochastic viewpoint, general branching processes and age-dependent branching processes of the kind of Bellman and Harris also result in the renewal equation. So you have these two worlds coming together to express and understand the infection process in renewal equations. And why this is so important is it's a mechanism for reality to some degree, in the sense that in physics we have these equations that describe the world with a certain degree of precision. The renewal equation constrains function space to epidemiologically plausible functions. Now, this is a fundamental framework, and so what we're presenting today is essentially the very bare bones of a body of work that we have used to estimate the effect of non-pharmaceutical interventions. That was some of the earliest work that we did right at the start of the pandemic, and then we did more work on it after in terms of looking at resurgence. We use this in mobility to understand resurgence in the United States. We use this to explain epidemiological trends in Manaus. And we use this to assess the transmissibility and immune evasion of the alpha variant, then B117. Now, another motivating example of why I use the renewal theory, and this is the background, is there are really a lot of equivalences, which I think are quite remarkable and beautiful. For example, SIR models that are very common from Kermack and McKendrick's seminal work in the 20s are linked to renewal equations, so there's an explicit link between them. Hawkes processes, which is another very well thought out process for modeling an infection mechanism using a doubly stochastic point process, in expectation is also a renewal process. More recently, the Erlang distribution in the SEIR epidemic, which model, which of course is linked to the SIR model, is also resulting in a renewal equation. And these equivalences abound up to autoregressive infinite processes, which have their link to Hawkes processes, but also when you look at the autoregressive equation and the renewal equation, you see that they essentially have a similar filter. So there are lots of equations and connections with other models that are suitable for infectious diseases to the renewal equation, and that motivates why we want to use the renewal equation. So I'll just hand off to Axel now, because he's far better at explaining this.
Thank you, Sam. So my name is Axel Gandhi. So yes, this is basically what I try to do is talk you through some key things in the model, a little bit of motivation. Of course, more details is in the paper. So you can, of course, motivate a lot of these kind of models where you have some latent infections as some sort of continuous time counting process if you wanted to. You can have, say, if NI is your process counting the infections, then you could postulate that the intensity of this process, NI, is basically given as an integral with respect to this counting process of some kernel that you may have, basically this time between different infections, multiplied by a time-varying number, time-varying reproduction number. And this would be, in principle, a model for the infections in continuous time. That's, of course, essentially a formulation of a Hawkes process. Down there you see the standard plots of what you see in a Hawkes process in terms of intensity. Here you probably wouldn't be saying these immediate jumps in intensity once an infection occurs, simply because there are time lags between the infections and the infectivity going up. Now, we didn't really use the continuous time framework. We went back to a discrete time framework by essentially just taking expectations of these. We basically model the expected number of infections as initial numbers of infections plus, it's basically just taking the expectation of the previous equation. And then, let me try to go to the next page. I think the key thing that you should be looking at on this slide is basically the expected number of infections in the model, and of course this is not the only model of this type, can be, or we assume can be written as, well, what is here on the right-hand side? This is basically a sum over previous time points. That is the number of previous infections at time point S. Some kernel describing how quickly infections lead to new infections. And one of the key things in our model is that we will be modeling this time-varying reproduction number. So this time-varying reproduction number is not just a number, it's basically something where covariates can go in there, interventions can go in there. We use these sometimes to link different regions together as well. Just to say, of course, there are few things in the modeling eventually which we will have to assume. We never really get to see, for example, this generation time. We don't really know when people exactly were infected. You probably see more things like serial intervals times between actual onsets of infections. At the end of the day, we basically assume that these distributions are similar or the same. But the main point is there's, in these models, things that we need to pick are, for example, this G is something we need to pick from other studies using basically other information. Now, one thing, I'm mentioning this because it was in this paper, is one of the things that came up in this model. Eventually, once you start fitting these models, at the beginning of the epidemic, everything looks fine, but then you start to point, hang on a second, we probably go to population saturation, at least with very low probabilities. Our models are complete Bayesian models, so the sampler may go to certain points where it thinks we get relatively high number of infections. Obviously, we need to have some mechanisms of dealing with that. Now, the first thing you might want to do, and that's the first thing we obviously did is, well, we just, if you want to look at the expected number of infections, we just take, basically this L is just the aggregate over the previous infections times the G. R is our time-dependent reproduction number, and we multiply this by a factor. This is just the number of the total population minus how many have been infected so far, divided by the total population. The problem with that, as it turned out, was it allows you to overshoot the total population, simply because it's essentially a difference equation. And of course, it's possible to go a little bit beyond. Now, what we then did as an adjustment for this one is we went back to the continuous time model. In the continuous time model, basically this factor would be continuously adjusting. So here's written as an intensity, the factor, but now this factor depends on how many infections are up to this continuous point in time. That basically gives you a differential equation, which you can solve. And then basically, with the population adjustment, instead of having basically a factor in front of it, we end up with, well, this formula here. And the nice thing about that one is it turns out that, well, it stops us from overshooting the total population, which is obviously something relatively desirable, but it also makes the entire sampler more numerically stable, and of course is, in a way, scientifically more reasonable. You don't want to have a model that can produce things that are physically impossible. Okay. Now, another key thing in our models is that we, well, I've described basically the main thing, how infections happen, how infections trigger new infections. The other bit that we, of course, we have to tie this to observations. And basically, the way this is usually being done is we have some observation, let's call it Y, can be number of observed deaths, could be cases, could also be something like results from surveys, or anything of this type. And the idea is that the expected number of this observation is modeled as, now I was the previous number of infections, pi is some sort of weighting of these past infections, basically how long it takes for this infections to show up, and alpha is some ascertainment factor. What proportion of say, the latent infections would I actually see? Now, down there's a little bit of, in this diagram, you see there's a lot of the things that go into the model. Let me just recap a little bit. So we have, so the formula above here is basically what's going on there, how I go from modeled infections to modeled death. Before that, I had how infections cause each other. That was basically what I had in the previous slides. And in there, things like a basic reproduction number goes in as a parameter, which we, of course, we will try to estimate, and then other covariates. These could be country-specific interventions, what kind of measures you did in this country, but it could be, for example, some factor for the amount of mobility observed. It could be all sorts of different things. Okay. And one thing, just to recap, the observations here. Now, this was basically, I'm saying this is the expected number of observations. Obviously, for the real observations, you need to have some sort of distribution around the expected number of observations. And reality was usually just having a Poisson count or something like that wasn't not a good idea. You usually have some sort of over-dispersion that you needed for that. Also, the question is always how fine do you take these observations? Do you use daily observations or weekly observations? Weekly might be an advantage that automatically evens out some weekly effect, that you don't have to specifically model that. Okay, and another key thing, I've probably said a few times already, that in our model, one of the key things we've been modeling is this reproduction number. Now, this is just basically one way, that's probably one of the main ways we've been doing this one. Reproduction number is some link function. We've used several different ones throughout in these various models. Quite often there was some basic reproduction, some parameter for each m was which region we were in. And then we had some linear combination quite often of it could be, these x could be intervention indicators, but could be a set mobility or something like that. The effects, we had various ways we could interact with these things, fixed effects, random effects, some partial pooling. So in a way, several things you could do in a regression framework, in particular in Bayesian regression. So this is the bigger framework of a kind of types of models we were looking at. And I think now it's over to Sam to talk a little bit more about the specific examples we have in the paper.
You got 12 minutes.
So, as I said before, this is a framework for which we've done a huge body of work over the period of the pandemic. And now I'm just going to go into some simple illustrations just to understand, how one can use this framework. But of course, these are very basic. So, the larger examples require far more thought and appealing to fundamental epidemiological principles. So, revisiting again why we use this whole framework, right? So the renewal equation constrains function space. And when I say this, I mean, when we go into time series forecasting, you could just use an ARIMA model, a Gaussian process, the whole array of these infinite dimensional functions that you then regularize down. But by constraining the plausible functions to those to be epidemiologically relevant, we believe that we can somehow control the mechanisms. It can produce better forecasts, and of course, this isn't always the case, but this is the hope. These frameworks allow you to incorporate lags. I'm sure that many times in the pandemic, there's always been these discussions about, well, cases are going down now, but that means it's something in the past. An infection happens, that infection progresses either to symptoms get registered as a case, cases go to hospital, in the terrible case, cases die. There's a whole bunch of lags in here that this framework allows you to account for so that you can understand the more fundamental factors. What is the rate of transmission at any given time? I haven't touched on epidemiological constants. Now, I think I'm the only one who actually calls them these. So they're basically, the generation interval, the serial interval, the ascertainment rate. I call them epidemiological constants for some appealing to physics. They're essentially these parameters that you use in this model, but require a huge amount of work to determine, and they change over time. For example, the generation time has changed with the new variants as time has gone by. One fundamental problem with these models, or it's not really a problem, but it's a challenge, and I say it as a challenge because I'd like to appeal to others to work on this, is seeding, which is how do you start the infection process. The renewal equation generally starts from one infection and then you move onwards. The time of that one infection is challenging. You can use phylogenetics, but none of these, the index cases and the time of the index case is very difficult to ascertain. And identifiability and collinearity, fundamental problems in all applied statistical models, are still resonant here. So let me go through a little case study just to talk through. So what we have here is a bunch of interventions. I'm going to use the very coarse intervention definitions we have there. Schools, universities, self-isolation to fail public events, lockdown, social distancing encouraging. I'm just going to consider the first wave of the epidemic. I realize there's much better data later on, but this was just a sort of illustration of what you would have to do in the first wave. Now, we had mobility data. Now, as someone who's worked in epidemiology a long time, it was very surprising to get mobility data from Google, but it was wonderful because we could finally start using it. And so we have that mobility data, that's that black jagged line, and we can fit a state-of-the-art STAN horseshoe shrinkage model, GLM, to that, and we get those coefficient effect sizes there. We can also lag mobility back and forth, and what we see is more or less what we'd expect, that there is a relationship between when interventions came into place and the changes in mobility. And the amount that these interventions changed mobility is shown in that effect size plot. Now, this is just interventions in mobility. The point of our framework is, in the early epidemic around March or April, of course, there was not enough testing. All we had were records of who's dying. And so we can use our framework to then back calculate from an observed death to a model death to a model infection to the reproduction number, and as Axel said, parameterize that reproduction number using the army and array of statistical methods that we have. So in the most basic case, using a simple shrinkage model, so you get an estimate for the reproduction number using our model, accounting for all these lags, and then you try to explain this reproduction number. So it's a two-stage approach. You end up with these effect sizes, which are broadly similar to what we had found using the first model that we did ever on this, and to some degree not that surprising. However, the question then begs, I've just used intervention timings here, but we know that the true infection process, the reproduction number, is driven by contact patterns, it's driven by behavior, it's driven by the way people behave and act and socially constrain themselves via culture. It's all these things. And all you have here is the timing of interventions as a proxy. So one could say, well, what if we just use mobility instead? And if you use mobility instead, you see, again, a huge effect size. So, we're starting to conclude here that interventions had some impact because we have shrinkage priors, right? These shrinkage priors can just regularize out if they have no impact, and we can get very poor prediction performance. But we think that mobility also has an impact. So the next question is, what if we put them all in together? And this is where the sort of standard applied statistical tools need to come into play, because now we see that there is broadly an effect for schools and universities and for lockdown, and we don't see that significant effect for the other interventions. But we see a very large effect for mobility, of course in the other direction because of the way it is. But mobility is having a large effect on transmission, and lockdown is having a large impact on transmission, and the other interventions are. Now, if we pick lockdown, and I'll touch a little bit on, because lockdown is a very sensitive subject to talk about, but I will touch on what lockdown means and the challenges around that. But if we just consider lockdown and mobility, and we're wondering to ourselves, well, what really happened there? Did people just start changing? Did mobility move in with lockdown? A very simple question we could ask ourselves is, was mobility mediated through lockdown, right? In the sense, did lockdown change mobility? And this is a very simple causal question that we can do via causal mediation. And what we do is we fit the reproduction number. We have, as Axel said, one of the nice things about this framework is it can connect to GLM type frameworks, and that's the way we've done it, right? You have a link function, and you have a series of linear terms. And in this case, our link function is exponential. So we have a model for lockdown to estimate the reproduction number, just one coefficient. But then we also can have a model for lockdown and mobility and the reproduction number. And given these two equations, we can have the most simple causal mediation. Now, I of course will acknowledge here, this is the simplest possible case. We know how much is going on. It's just an illustration, and I think perhaps shows how difficult causal questions are. Because I'm doing the most basic thing, and it is quite difficult to make progress beyond this, because causality is so challenging and is unfortunately ignored very often. And I think this is where large amounts of research need to go into to really develop the tools to do this. And what we find is, I say unsurprising to me, but is that mobility was mediated by 18.3%. So lockdown essentially, mobility, the joint effect. So mobility sucks up some of the coefficient size from lockdown in this mediation. So just to go through the broader context, just to show that we aren't just focusing on the simpler questions. We have in the past put all of this together in a holistic framework. So I've gone on very simple intervention definitions, and that's a problem. I've gone on very simple linear, albeit regularized linear effects for interventions and mobility. But we can, for example, use a stochastic process along with these linear terms and do regularization, for example, using a random walk process. We can expand our interventions. We can do a study design. We can do this using cases and deaths, not just deaths, as I've shown in our little illustrative examples. And you can do a lot more. So the broader context is that this framework gives you the starting point for which you can really use the army of statistical tools that exist there. But it starts from a fundamentally built-up epidemiological perspective, and that's why I think it's very powerful. So just touching on the last few bits now. All models are, well, I don't know if it's just my opinion or true, but if you can't recover from simulation, there's a problem. I think we can agree. And so here's just a few simulation examples to convince you that our model has some degree of identifiability. So here we just do a simulation from a fake epidemic where we know the effect sizes beforehand and we're trying to estimate them. And we say here, all non-pharmaceutical interventions have an effect size of 20%. And we see broadly that we do capture it. Let's make it a bit more challenging. All non-pharmaceuticals have an effect size of 18%, but there's an unobserved NPI with an effect size of 10%. And this is where some techniques from the social sciences like partial pooling in mixed effects regression really help. And again, we broadly find consistent effect sizes. And then finally, we say that only one NPI has 70% and the remaining NPI has 30% distributed across the other 4. This is a common scenario. And we see again, once again, we recover the effect sizes. So this is simple simulation. I can break this very easily. I could add a random process behind this, and I would not be able to get the estimation correct. I can break it very easily, but the point being is that if we account for all these effects mechanistically, we think there's a random process that perhaps accounts for behavior in a dynamic way. Great. We have lots of stochastic processes to choose from. Let's just choose one of the various Gaussian processes and put them in there. And so, finally, just to touch on the last 2 points.
2 minutes.
2 minutes, perfect. We have a bit of software out here, Epidemia, that has been developed by one of our co-authors, Jamie. I think we need to have a lot more of this sort of consistent computer programming type work to translate this basic software. I hope I convince you that this is a good framework from which to start and build. Well, mathematically that might be true. We need it to also be computationally true so that it's practical for the next pandemic around. So I really want to also be finally upfront in the last few minutes about the challenges, and there are so many challenges in doing this, and I think everyone knows this. You know, the number one is the definition of interventions. You saw that the case I chose, and purposely chose them because they were poor. The interventions we chose were informed on March 30th, 2020, with limited knowledge. And you know, we used lockdown, for which the definition, there is really no definition anymore because different countries' lockdowns are very different. The Danish lockdown, the UK lockdown are not the same series of interventions. Lockdown constitutes a package of interventions, and which is why in further work we didn't use the lockdown, we used the actual interventions, banning gatherings 2, banning gatherings 10, banning gatherings 5, public or private retail closing. So definition of interventions is extremely important, which leads to the second point. These are all proxies for behavior, and behavioral surveys like those done in Comics are integral to informing these models. Of course, garbage in, garbage out, right? Contact patterns are even more important. Now, we tried a bit of this with mobility, but really what's happening is people are contacting and infecting each other. And so the better we have an understanding of contact patterns, the better. Epidemiological constants are fundamental, and we were lucky in the pandemic that many people did continue to generate them, but they are as important as these models themselves, because we are downstream from them, so they are fundamental. Generalizability is a very crucial question. We have initially thought we could create a model for NPIs, and then we found that these models don't generalize to different countries. What you do for Germany does not work for South Korea. These models do not generalize in time. People's behavior changes dynamically. The interventions change dynamically. Background interventions like putting screens up in shops change. So generalizability is quite difficult. There is no fundamental effect size here for one intervention. It changes dynamically over time, and so these models need to be run repeatedly. Misspecification and causal bias is huge, right? You know, these models could benefit from the great body of causal learning theory using double robustness, using targeted machine learning or double machine learning, the double maximum likelihood of double machine learning. Model misspecification is, of course, huge. You leave out something, and you might have a misspecified model, and you can use all the statistical tools in there. Inference and computation tractability is challenging. We benefit from probabilistic programs like STAN, and I think that's another huge area of research, right? Renewal equation is quadratic. Approximations might be better. Great.
I take you to Norway. So how was the pandemic in Norway compared to England? There was a difference. Here you see the number of confirmed cases, lab confirmed cases in England and Norway per 100,000. And the peaks are different. And you see clearly that except for the Omicron, the disease has been tougher in England than in Norway. Here you see the number of patients in hospital per million, a factor sometimes more than 10. Also in the last Omicron wave. Despite the fact that Norway was very late in vaccination, later than the UK, later than the European Union. And here you see deaths per 100,000. Norway was one of the countries that had less deaths in the world, together with countries in Asia, of course. So what is all this? Why did this happen? So the government had quite classical objectives, right, that many countries shared. Maintain a manageable burden on healthcare services, prevent deaths, in particularly elderly and vulnerable groups. And the strategy was based on prevention of uncontrolled spread of the epidemics by very timely and efficient contact tracing that was locally organized, by mandatory quarantine and isolation, by border restrictions in different periods, and by various forms of sort of lighter lockdowns. But everything early enough in the exponential growth. And this early enough has been probably very important. And models, statistical and mathematical models, have played a role in allowing rapid decisions by describing the situation and making predictions. So what was the current situation every single day? What is the situation? How will the situation develop in the next 3 weeks? And what if scenario simulations were also very important. We estimated the daily reproduction number that we've heard about already. We predicted how it would develop in the next 3 weeks, and the prediction of hospital incidents were very, very important. All this estimation had to happen very rapidly. We had about 24 hours from when we received the data to producing results, which gives a lot of constraints and implications on what models and what algorithms you can in fact run. The data in Norway were quite good after May 2020 at least, with a national registry, despite the complete lack of randomized prevalence studies that you have in England and that were very, very important. We never succeeded to convince them to do these things. The effective reproduction number changes daily because, as we heard before, non-pharmaceutical interventions change, the behavior of people changed very much, depends on season, depends on other things, and the variants were very different, and vaccination strategy. And the reproduction number changes both smoothly and abruptly, and it can change rapidly, very, very rapidly, or slowly. A complicated process. The data that we use in this study are organized in the 11 Norwegian counties. Oslo is one of the counties. And we used essentially two sources of data. The daily new admitted COVID cases in hospital. This is the best data, but they have a delay of approximately 2 weeks. And the PCR confirmed lab data and the number of tests also of varying quality because of different strategies and different capacities of the testing in Norway. But on the other hand, they tell us something more that happened more recently in the infection. Every county has its own local epidemic, but in this paper here we share the reproduction number across the whole Norway. And the counties are connected through mobility. We use as a proxy for mobility, mobile phone mobility. That is a surrogate of real-time movements of individuals. We have received, during the whole epidemic, every 6 hours data from Telenor, the major mobile phone operator in Norway, aggregated at level of municipalities with some small censoring, and then just scaled up to the whole Norway. We can say that our models have had an impact. So this is an example where we produced a report on the 10th of May saying something on how the vaccine strategy should be organized geographically in Norway, and 10 days after the government took this decision. Geir, let's go over to methods.
Right, so I will go more into the technical details of our approach and starting with an overview of the model that we have been considering, mainly consisting of 3 submodels. One saying something about the transmission of the disease, one saying something about the dynamics of the reproduction number, and then finally the likelihood for the data. In addition, we are using a Bayesian inference approach, which means that, or at least partly, so we have some priors on some of the parameters as well. And the aim then is to do an inference based on the posterior distribution. And there are, at each time point, approximately 3,500 variables or parameters to estimate, and combined then with 800 days, it's quite a high-dimensional problem. Starting then with the model for the daily reproduction number, we are using quite simple models here, so a bit different from the previous talk in that we mainly model smoothness. And this we do through 3 alternative models on the log scale, mainly autoregressive or random walk models, but we also have included a piecewise constant model due to that is quite similar to many other approaches available. We have for each of those models some parameters which we mainly use some simple but somewhat informative priors on, more described in the paper. For the transmission of the diseases, we are using an SAIR type of model with 6 different compartments, but perhaps the main feature is that we distinguish between symptomatic and asymptomatic infections, which also then influence the amount of new infections, which also is then driven by the reproduction numbers. And then finally, for the likelihoods, we have 2, as Arnoldo mentioned, we have 2 main sources of data, hospital data and test data. Both of them are a bit complicated due to that we have delays from infections to the actual observations, and those delays are different from individual to individual, so we describe them stochastically. However, both the data sets are mainly based on probabilities for hospitalization given infections and similar probabilities for testing positive given infections. And looking at the hospital data first, we assume then that this probability is changing over time, mainly then depending on the age structure of those that are tested, but also on the vaccination status in the population. We may use a beta binomial model here in order to take into account over-dispersion. And similarly, we do that also for test data. We have a beta binomial model there as well. But here we describe then the probability for being tested positive related to the number of actual tests taken through a logistic function where the parameters are estimated from external sources. It's mainly the probability for hospitalization that has changed during the pandemic. And the plots here show then how it has essentially declined quite a lot through the pandemic. And this is partly due to changes in the age structure of those that are infected, but perhaps mainly due to that more and more people are vaccinated. Combining all these components into a kind of directed acyclic graph, we can see that we have, for especially then the reproduction numbers described here by RT, but also the transmission or compartmental vector described by ST here, have quite simple first-order Markovian kind of structure. However, linking this to the data is a bit complicated due to these stochastic delays, and that also makes it computational a bit hard due to that the likelihood is not clearly specified. This we solve by introducing a set of auxiliary variables described by ZT here, mainly distributing then the number of infected into following days, so that we can link them directly to the observed data. And in this way, we can actually then say that the observations at time t only depend on the current auxiliary variable ZT, while the ZT now has a simple first-order structure, a Markovian structure again. And then we get a simpler type of DAG, where now all the observations are conditionally independent. We do lose something with this approach in that the dimension of the latent field increases quite a lot, but still it has been quite manageable. So summarizing all these components, we now actually have 4 main components in the model. One describing the dynamics of the reproduction number, one describing the transmission, one describing the delays, and then finally the likelihood. And then combine them with priors on some of the parameters, we can then make inference. And to simplify the notation a little bit, also here we have combined then all the latent variables, which in this case consist of both the R's, the S, and the Z's, into one long vector V. And in this case, we can write it down as a more classical type of state space model with a Markovian structure of the latent vector V, and then conditionally independence on the observations. And the aim then is to do inference on both the parameters and all the latent variables simultaneously based on the given observations. And the computational tool that we are using is then sequential Monte Carlo. And the main difference of this approach compared to the more standard use of Markov chain Monte Carlo is that it utilizes the sequential or dynamic structure of the model. The actual algorithm can be described rather simple in that, assuming that we have samples of the latent variables at time t-1, the aim then is to propagate those samples to the next time point t. And that is done through two main steps. First, a forecasting, where we simulate the new latent variables based on the transmission model or the transition model. And then we link it to the new data that arrives by calculating weights and then updating the posterior distribution and samples. Now, when we do this over time, a problem will be that some of the weights will be very low, while others could be high. And in order to compensate for that, we are including also then a resampling step. So those samples that do not fit very well with the data are discarded, while those fitting more with the data are taken further and perhaps made multiple copies. And there's a graphical display of what is happening. This is a very simple setting where we just have 5 samples and a one-dimensional latent variable, but mainly describing then that we start at time point 1 with 5 samples, but some of those doesn't fit with the data, so they are discarded, and then the others perhaps are made multiple copies and moved to the second time point, and then this is repeated over time. And then at each time point we get samples then for the posterior distribution given the data up to that time point. There are, of course, a lot of challenges and decisions to be made when you try to make such an algorithm, where perhaps the most important one is how to propagate samples from time t-1 to the next time point. We have chosen to use a very simple approach, which is named the bootstrap filter, where we essentially are using the model itself when we do this propagation. There are several reasons for that. One is that, well, first I got this telephone from Arnoldo in May 2020, and he wanted something in 1 week. And then we couldn't do that sophisticated thing. So we had to stick with something simple. But also the bootstrap filter, the simple one, has some benefits in that it's quite generic and it's very simple to change the model without having to change the code that much. And in addition, we also had some limitations on that the transition model that we are using only was given as a computer code, so we were not actually able to go much into that code and modify it. That results in an algorithm that is not perhaps the most efficient one, and we compensated by that by using then high performance computers with parallel computing and many cores in order to produce reasonable results. The algorithm described so far in some sense assumed that the parameters were known. But we would like also to estimate some of the parameters simultaneously within the sequential Monte Carlo. Some parameters were estimated externally, some were fixed by other external sources, but especially those parameters involved in the daily reproduction number process we wanted to estimate simultaneously. In principle, we could write easily down the posterior distribution, but it's not that simple to simulate from that. So what we used is then also a rather simple approach based on what's called sufficient statistics. This is based on that the main challenge when using sequential Monte Carlo is how to actually do the forecasting, how to sample new latent variables given the history. And this becomes more complicated when unknown parameters are involved. And I apologize that there is an extra theta there, that shouldn't be it, so it's not an expectation of theta, that should be removed. But the main issue here is that we don't actually need the density itself. We only need to simulate from it. And that can be formed through two steps. First, by sampling the parameters, given the history of all the latent variables. And then, given that we have now the parameters and the history, we can simulate new latent variables. And especially the second part is quite easy because it's just to use the transition model again. But the first part could be problematic depending on the model structure. But in cases where this distribution for the parameters given the latent variables is based on some low-dimensional sufficient statistics, which in addition are easily updated, then this approach is quite achievable. And this is the case for the parameters involved in the reproduction number process. So this is what we have used, and here you see one version of the results where we are estimating then dynamically and online the variance of the reproduction number process. And we see that then when we get more and more data, the precision increases. I should then note also that this procedure has been criticized in the literature, in that when the time horizon is increasing, it has some poor properties. But within the time horizon that we have been working on, combined with that we have not done this on many parameters, then it seems to work quite reasonable. And then Arnoldo.
Let's look rapidly to a few results. Yeah. Here you see the estimated reproduction number in blue with a credibility interval from during the whole epidemics from the beginning until a week ago. In red, you see a credibility band where we used only the hospital data, instead then the hospital data and the test data. And the running time for this is a couple of hours, and today when we run it every week, we only increase it so it goes very, very fast. Let's look to be a bit more carefully to this wiggling curve, right? In the beginning, you see the reproduction number was just below 3 in Norway. First lockdown collapses right away below 1. Then the lockdown is kept alive until the mid of April. Then there has been a gradual reopening, and the reproduction number goes up to 1. Here you see that it remained then during the summer below 1, but just after the vacation, everybody goes back to work. End of July, a jump of the reproduction number above 1. You see how sensitive this is to these different behaviors. Several large clusters that in different parts of Norway that were controlled can be seen here. We can identify them quite carefully. Second lockdown at the end of October. It was not enough to take the reproduction number down below 1, so there was a strengthening a couple of weeks after. It was necessary, and then the reproduction number was below 1. Christmas shopping. Everybody was in the open shops. Jumps up. Third lockdown in January 2021. It was the hardest lockdown in Norway. That was then sufficient to take the reproduction number far below 1. The alpha variant comes and things get worse immediately. But then in May, the vaccination the coverage started to be decent. What is interesting to observe here is two things. First of all this wiggling, right? We interpret this by thinking that these are in fact there. That these are local outbreaks that have been controlled. Another interesting thing is that you see that the red curve is smoother than the blue one. So when we use only hospital data, the reproduction number is more smooth. This means that the test data add information and carry information which is important in certain moments in particular. You see a fit to the hospital data. The red dots is the truth. The blue things is our estimates. This is just to show that the variance that we estimate is maybe okay. Prediction 3 weeks ahead. The red dots here is then what happened in fact, and more or less covered by the 95% credibility intervals. We predict also the incidence here that, of course, we don't have the truth. But this was very useful, for example, in dimensioning the contact tracing groups in Oslo. Currently, we have a model that is run with a reproduction number which is different for every region. This has been for the last year. So here you see 11 reproduction numbers from last week, some clearly above 1. This is Omicron 5 that is coming. And the prediction of the hospitalization for the next 2 weeks down there for the hospitals in the Oslo regions show that this will not create, however, problems for the healthcare system. I can close by connecting to this concept of interoperability that has been recently proposed by George Nicholson and several others, interoperability of statistical models and pandemic preparedness, principle and reality. So the concept here is that one can build very many models that take care of parts of the data, hospital tests and so on, and then try to merge them in some way. This is one extreme of the modeling strategies. The other one is to make a mega model which everything included, right? And the conjecture, I'm citing the paper here in red, our conjecture is that in the face of the constraints and operational challenges, time, for example, there is an optimal middle ground in which we develop models and analysis plans, a couple of them, and couple them. And I would like to conclude by saying that our approach fits very, very nicely in this interoperability concept. It shows that this idea is probably correct. We use multiple and evolving data set of different quality, and we effectively try to do a synthesis of them. And these data sets are very often in conflict with each other, so that the models have to take into account this important part. We try to propagate uncertainty properly, and very importantly, the model is very modular, so that it is easy to correct parts of it without re-implementing the whole thing, which is necessary in the current situation. Thank you.
Of these two papers, which both have shown light on how, in response to to urgent public needs and policy questions on effectiveness of intervention, then epidemic modeling coupled with Bayesian inference has been successful to provide decision makers with much evidence in near real time. So. Throughout the pandemic, we've seen a range of modeling approach being developed, and I think if you look at the work of SPI-M, there's a real ensemble of models. Here we have two of the main approaches, and which really reflect the main approaches used internationally, the renewal model and the compartmental models. And they differ, nevertheless, in several aspects, as you've seen by the very different presentation that we heard. So I just wanted, before I discuss, before I go to discuss each paper separately, I wanted just for the audience to have a table which outline, basically some of the complementarities, some of the commonalities, and so on. So, the root is the same, semi-mechanistic stochastic model, as opposed, for example, to agent-based style models, very different types of way of going. They also both use Bayesian inference framework, even though the algorithm underlying are different, Hamiltonian Monte Carlo, which is the root of the stat, versus this sequential Monte Carlo, as we heard Geir say. Otherwise, I think the focus of there are many differences. The focus has been quite different, The first paper that we've heard is a very generic, we're trying to capture the idea behind the renewal model and in a very generic way, and also propose lots of potential extensions. Whether the second paper is really a standalone piece of work from the beginning to the end, to focus on giving an answer for Norway. The level of evaluation, for example, and comparison, which is made in each paper, is also quite different, and the level of technical details that was given aligned with basically their purpose, which was quite different. The discussion that were presented for the first paper were like illustrative examples. The second paper was really trying to give the best answer that they could, given the situation. So, nevertheless, some of my comments will be on some of the nitty-gritty of some of the statistics, because this is what I am. I'm a statistician, not a modeler. One comment about these different, basically, renewal equation or the stochastic compartmental model, as Sami pointed out, they're equivalent under self-distributional assumption. And in fact, there's a really interesting graph in the Stovik paper, which compared APS-10, which is based on renewal equation, with a compartmental model. And indeed, you see that the basic trace plot and the behavior, the time series, very much coincide. But nevertheless, for the APS-10, the interval of variability is you can't even see it around the red line. And so basically, while the mean behavior is very corresponding, the way these models were estimated or something means that the variability has not been well captured by the APS-10 model. In general, I think it's very important to demonstrate good calibration of uncertainty. And this was done in the Stovik paper, and I think this is something which is important to demonstrate every time you actually produce a model. So I think we should pay attention, and as statisticians, our duty to insist on the point that it's not just the mean behavior, but the decision makers, they need a good calibration of variability as well. Now, if we go to the first paper, so in terms of the extensions which were produced, there were two types. One for accounting, parameters. You've called them epidemiological parameters to account for the observational process. And then secondly, an extension to actually use kind of evidence synthesis method to pull observation from different, for example, different countries or different regions and so on. So this observation equation, which is in many form, and there's many versions through the paper, starting, equation 2, 6, 8, and 7, and 8, or something like that, has these two components which are very important: the ascertainment process and then the distribution pi of the lag. Now, the ascertainment process, here it's only written as an alpha t, but is indeed an important element. But it's not clear to me what information is needed, and in particular, if you're thinking of that in terms of the 8 countries there, or the 11 countries that were analyzed, what information people would have to actually capture this ascertainment process, which is indeed important. Some work that we had done recently in the Turing RSS lab, we focused on ascertainment process. It was only possible to identify that by combining observation with a randomized surveillance. But in many countries, there hasn't been any randomized surveillance, and so what would you do to capture the ascertainment process? This is a question of interest. And also to say that it wasn't a straightforward, to this combination took a lot of work, and it wasn't really straightforward to actually do that. Now, the second type of extension in the first paper is to basically have many different countries or whatever, and then propose that you pool information about these types of data. Now, this opens to me some serious issues of potential conflict between the data sources, an issue that, in the MRCVSU, people have been concerned in many guise and form. I noticed that in the Storvik paper, you used both hospitalization successfully and tests. I was wondering whether you had any conflict and in particularly in this delay distribution, because this delay distribution, as was clearly stated, they rely on external information, so additional information. There's nothing in the data to actually estimate this delay distribution. But if they're in conflict between two types of observation, then what's going to happen? And so, my conclusion of that is that, I think we've learned a lot about epidemic modeling, and now, we've got really general tools and thought, and we should focus attention on the observational process and preparing the type of design, the type of data which are needed, for example, to communicate this delay distribution and also share data about them. We won't have the princess data in any other situation necessarily to be able to anchor this model. So I think we should try to all of us focus effort on thinking about the observation process and what type of data will be needed to actually get a handle on the ascertainment, get a handle on this delay distribution, and also share these data so that different models can use the same type of data to actually do this thing, which can be more coherent with the model. Now, turning back to the mobility analysis, was glad to hear it was Google mobility. Of course, I guess it was Google mobility, but it wasn't really mentioned at all, unless I didn't read it well in the paper. I have some question about your first bit of the analysis, this two-step hierarchical analysis. I mean, using two-step hierarchical analysis has a long history in environmental, for example, epidemiology, where you extract summaries. For example, there's a paper read here by Francesca Dominici on air pollution in cities. So she was having 20 US city time series that she was pulling, then doing pooling synthesis of these results to estimate the effect of air pollution on mortality. But typically, if you do that, the first step of the hierarchical model, you need to use, you've extracted a summary, it's a statistic, it's got variability. You need to account for this variability, and I didn't see that done here. Secondly, I know it's only an illustrative example, but nevertheless. And again, also the residual, basically if you are having as Y an autocorrelated time, very autocorrelated time series, it would be natural to look at the residual and check whether they're autocorrelated or not. When you've only got 11 countries, there's also influence of what prior you use for pooling. And finally, the use of shrinkage prior, useful when you could have singularity, might nevertheless distort the respective part of your very highly correlated predictors. So I think there's still quite a lot of question marks on these, remaining on the intervals. I would imagine the mean behavior isn't going to, but again, the intervals, which is important on all of these estimates. Finally, for the causal mediation analysis, which already in the first paper by Flaxman and et al. So of course, you've absolutely indicated that in your discussion. Mediation interpretation relies on very strong assumption, and I think two of them are which, apart from all the others, are directionality in the effect pathway. We have to be sure of the direction of the arrows, as well as this usual assumption for any causal analysis, no confounding variable. And social behavior is clearly a potential confounders in there, and you don't even know the direction directionality, because where social behavior can influence whether you impose lockdown earlier or later. So this is really a complex process, and at the end of the day, all we had is 11 countries with a step, a sort of big step in the behavior, big step in all the variables. So really kind of little degrees of freedom to support such a causal analysis, in my opinion. And on the statistical front, I think that the error process there, which is going to absorb, these big changes in the arm, these fast changes around the lockdown. I think how the structure given to that process would be influential on the estimates. And here you used a random walk, but was it a fixed variance? Because I would imagine that there's quite a lot of variability, change of variability going on, which need to be soaked up by this epsilon, which will have an influence. So lots of plots, lots of plots showing residuals and so on, to really robustify the conclusions.
So could we just have 1 minute?
Over 1 minute?
Just 1 minute left.
Okay, that's fine. This is my last slide.
Okay, great.
We're coming back to the model of Storvik. I mean, compartmental model, and they provide, of course you got the RT, but you've got additional information about the size of the compartments and prediction of the size, which are very useful for both public health and for hospital planning and so on. So I think they've got a plus, even though, if you focus only on RT, there would be equivalent. They give additional information which can be really useful. And I like the fact that you sort of refine the very rough mass action by using these regions and using the mobile phone data. But of course, you ended up with many, many parameters. Now, I was wondering on the uncertainty quantification, because there was quite a lot of plug-in of some parameters, and I wasn't sure that were you bootstrapping, were you doing anything for taking into account the variability of the plug-in parameters. And another thing I had trouble to understand, maybe it's the way it was phrased, was this smoothing 24 days ahead, because when you're here, were you actually forecasting 24 days ahead to be able to implement your machinery, or were you, the way it's written, it's like you need data 24 days ahead to actually do things when you're here. So there was something a bit, and I was wondering in general whether you would work, whether things would have worked with block updates. Do you really need to update all your proposal and everything day by day, or could you have, dispense with daily and invent proposal which would be still okay for a few days and then move from that, and so in general it'd be very interesting to hear whether what are, because you've done a very from an example of sequential Monte Carlo, are there generic lessons for implementation of highly compartmental models that you would recommend? So I've reached the end of my time, and also the end of what I wanted to say. And I must say I've really enjoyed reading this paper, and I want to congratulate both authors. And I'm very happy to propose the vote of thanks.
Yeah, Peter was hoping to make it, but couldn't at the last moment, and he asked me just to read out his contribution, which I'm going to do word for word. So the caveat, these are Peter's words, not mine. And he has a few equations and figures which I'll bring up on the slides as well, but again, I've copied those across exactly. So, so in Peter's words, both of tonight's papers describe important work that has contributed and with sufficient political will can and should continue to contribute to public health policy setting and decision making. The term semi-mechanistic could be applied to the modelling approaches used in both, the models being informed by a combination of data and context-specific scientific knowledge. I find it hard to disagree with this as a general philosophy, but striking the right balance is a challenge in any specific application. At root, an epidemic is a realization of a spatiotemporal point process, but is rarely modeled as such. For an exception, see Neal and Roberts, 2004. I'll put up the references at the end. More often, context-specific knowledge feeds the temporal formulation of the model as a set of discrete time stochastic processes, with the role of space reduced to the indexing of a small number of discrete units. Norwegian counties in Storvik et al., unspecified in Batt et al. Discretizing time is usually innocuous, both because of its simple geometry and the availability of data at a time resolution fine enough to capture the dynamics of the process. Discretizing space seems to be more questionable, certainly if the inferential goals include estimation of parameters that relate to the effects of spatially varying risk factors. Now, Peter has an illustration which I'll bring up. You'll appreciate this wouldn't be so easy to read. So if we take this purely spatial case for illustration, so if we let yi, I equals 1 to n, be case counts in a set of n aerial units ai that partition the study region, and let Sx be the unobserved disease risk at location x, and we write Si is the integral of Sx dx over ai, a very widely used class of models for mapping the spatial variation in risk, Besag et al. 1991, specifies the yi as conditionally independent Poisson variates with means given by equation 1, where the wi form a Gaussian Markov random field, di is a vector of covariates, and the offset oi is the number of people at risk in AI. Arguably, a more natural model is a log Gaussian Cox process, in which case the yi are again conditionally independent Poisson variates, but now with means given here by equation 2, where Ox is the population density and Wx is a spatially continuous Gaussian process. Model 2 delivers the joint predictive distribution of the complete surface Sx, in practice represented by a suitably fine pixel grid, from which the joint predictive distribution of the Si follows immediately if that is what is required. See Diggle et al. 2013. Inferences drawn from equations 1 and 2 can differ materially if important covariates are available at finer spatial scales than the AI as a consequence of the long-studied effects of ecological bias, Greenland and Morgenstern, 1990. For example, the current COVID-19 epidemic in England has typically been mapped at the level of England's 331 lower-tier local authorities, LTLA, for example, Riley et al., 2021, but potentially important covariates, including measures of deprivation and ethnicity, are available for each of the country's 34,753 lower super output areas, LSOAs, and they can vary substantially between LSOAs within the same LTLA. Reproduction numbers, however defined, might similarly vary over much smaller spatial scales than the ones to which epidemic models are typically fitted, which leads me to wonder exactly what property of an epidemic a spatially agnostic R number is estimating. Contrarily, I'm surprised that the time trajectories of estimated R numbers in figure 2 of Storvik et al. Show so much high-frequency variation, even allowing for the widths of their credible intervals. Do the dynamics of the epidemic really change so quickly? And if they do, how useful is an estimate of the current R number as a guide to real-time public health decision-making? Finally, I would like to comment on an issue that is perhaps beyond the scope of either paper, namely the reliability of the case numbers that informs the models. A recent WHO report gives worldwide country-level estimates of the very substantial undercounts in reported COVID-19 deaths, see Knudsen et al. 2022, and the problem can only be worse for case counts of a disease with, thankfully, relatively low mortality. Nicholson et al. 2022 show how to debias case count data by jointly modeling routinely reported case counts together with data from a randomized, hence unbiased, prevalence study, the REACT study, R-E-A-C-T, Riley et al. 2021. REACT was an England-wide repeated cross-sectional study of the spatiotemporal variation in COVID-19 prevalence over the course of the epidemic, based on COVID-19 positive-negative test results from samples, each of approximately 100,000 individuals drawn on each of 19 rounds over almost 2 years, as geographically stratified random samples of the NHS-registered population. The response rate was of the order of 20 to 25%, which the REACT analysis accommodated by adjusting for imbalance in the responders with respect to potential risk factors. Nevertheless, this leaves a niggling doubt that in studies of this kind, responders within a risk group may not be representative of the whole group. In the setting of longitudinal studies, this corresponds to the problem of informative missingness, on which topic many papers and at least one book, Daniels and Hogan 2008, have been written. The prevalence survey counterpart is harder to address because, unlike in longitudinal studies, there is no independent replication. Figure 1 outlines a possible solution. So here we see a figure, a causal diagram for informative non-response. Squares and circles represent observed and unobserved quantities respectively. Observed quantities are covariates D, number of responders Z, and number of cases among responders Y. Unobserved quantities are the response rate Q, true prevalence P, and a latent response S, representing unobserved factors that potentially affect both Q and P. Non-response is uninformative if the red arrow is absent. And Peter goes on to say that the predictive target is the true prevalence P, but in the case of informative non-response, the empirical prevalence depends on both P and Q. And I just show those references that Peter referred to, Besak et al., in alphabetical order. First page here, 4 references. And then on the second page here, a further 3 references. And that's Peter's comment. Thank you.
I had the honor of being a physician, a public health, public safety physician, a statistician, as well as an economist. I thank the organizers for having the opportunity to participate, especially after a long lapse of in-person meetings at various scientific gatherings, including the RSS. I found both papers by Starwick as well as Starwick et al. And Butt et al. Quite intellectually challenging, and much has been said about them already by the proposer, the seconder, as well as our president. So I will not be adding a lot to this. In commenting about Butt, Starwick et al.'s paper, in figure 2, I noticed that they've mentioned after July 2021, perhaps, you did prediction on Bayesian. Bayesian prediction was implemented in all 3 models of yours, and I was wondering, is there a place for Bayesian modeling, model comparison, and if that's something that you could include, especially since you, the authors from Norway, share a huge land border with Sweden, which had a hugely different approach to dealing with the pandemic. I was wondering if that's a comparison of your model performance as regards Swedish data is something that should be helpful in dealing with future approaches to pandemic control. I may be departing a little bit from tradition here in asking the authors in discussion meetings to make both the data as well as the code available so that participants can actually run the code as well as the data to see how it works out. Because as someone who's done 14 years or 17 years of as a peer reviewer, all that I get to see in many articles as a reviewer is only graphs and tables. And I have no means of actually replicating the data. And as this 1500, the reference is Nature 2016 by Baker, who looked at a survey of 1,576 authors, and they found that more than 70% of authors failed to reproduce previous studies, and more than 50% of authors were unable to replicate their own research. At a time when we're dealing with the reproduction number, perhaps the RSS can advocate for reproducibility of the data and of the findings from studies that are published in the under the RSS. So thank you very much for the speakers, and I'm hoping the RSS can take on board my request for reproducibility in research findings.
So first I'd like to congratulate both sets of authors on being able to produce high quality research while battling against the churn of weekly producing results and adapting models to data and working to short deadlines to inform policy and the pandemic response in the two countries respectively. We were motivated to reply to today's presentations through Gare and Arnaldo's citing of a paper that we prepared on data on a simulated epidemic designed to ape the dynamics of the 2009 swine flu pandemic, which we published in 2020. And it's a sort of, we feel it's a counterpart paper to what we've seen presented by Gare and Arnaldo today. So this is just some details of their presentation and their modelling approach. I was kind of contrasting that we're working with a deterministic mechanistic model. We're just looking at a single spatial unit, but stratifying population by age groups. We had multiple data sets involved in the model, and we didn't have a dynamic process capturing the reproduction number. But our focus in this analysis was using SMC to estimate static parameters of interest. And when SMC algorithms are proposed in literature, they're often on idealized pandemics that have a nice up and down shape. And they're not being tested in real time, they're being analysed retrospectively. And the algorithms always seem to work quite nicely. But we took a look at what practical considerations need to be made to actually get sort of reasonably state-of-the-art SMC algorithms to be used for real-time inference. And I apologise to Gare and Aldo. They did caveat their work that they've had criticisms for degeneracy, but I'm going to touch on that. So what are the issues that I'm talking about? And this is particle degeneracy. So at times what we call a system shock, and this is where the government has the temerity or decency to interrupt our nice SAIR model shape and impose some kind of policy on the pandemic which either interrupts our data flow or interrupts transmission, ideally. And so the pattern of the data changes, and we have to introduce new parameters, perhaps to estimate the impact of whatever intervention has been imposed. And the problem with this in a computational sense is that it leads to a sudden drop in the effective sample size of our particle set. So we're looking at here, the red arrow points at around day 80, and you can see at this point the effective sample size is on the y-axis on the right plot there, and it drops from about 10,000 down to, I think it was about 20, because we're having to estimate parameters that describe the size of that drop from a prior distribution, and we're doing it in real time. We have no prior information about how successful the intervention is going to be. So we had to develop adaptations of the SMC algorithm to sort of cope with these sudden shocks and new parameters being added to the system. And it requires an additional step to the one that was discussed. It requires an addition of a rejuvenation step. So just jittering your static parameter set. And we've had a recipe for doing that in a way that will give you decent inference, but also not compromise your capacity for doing it in real time too much. And the key features of doing this were sort of controlling the timing of rejuvenations, so tempering the data that we're adding in intervals, so that we're not adding in full weeks or full days of data. We add it in bit by bit, so that the effective sample size can never drop below a certain level. That's why there's a line along the bottom of the red plot there. Optimizing proposals, so making sure that we use what we know about the particle set at the current time to make sure we can move as far away and jitter our proposals as much as we can. Because we can recover the effective sample size by moving them just slightly, but we still effectively have a highly dependent sample. If we can move it a long way, then we really are replenishing our sample. And just generally, we had a method for minimizing the number of proposals needed, because we want to do this in real time. So why am I talking about this? And I noticed that Garen and Aldo started their process for the reproduction number, starting at the time of the major intervention at the beginning of the pandemic. We did the same thing in our modelling of the pandemic in England. So you model the reproduction number from the start of a major intervention. We've done the same thing in our modelling of the transmission parameter, the beta, instead of the reproduction number. We started doing it, it's flat before a major drop there on the top plot for the effective reproduction number. And then we start a random process after that drop. And that's the drop, that's the where we, and you have cheated slightly by avoiding that drop and the degeneracy it would cause.
Just 1 minute.
Just 1 minute, yeah, that's fine. So what we've done here is in A, B, and C, we've on the second plot there, we've taken away the effects of susceptibility and the gathered immunity in the population away from the reproduction number calculation. And the bottom one, we've taken away the effects of mobility and contact rates. And as you can see, the process on beta, rather than the reproduction number, this is effectively beta at the bottom. The process on beta is much more smooth and would be less prone to degeneracy if that was modeled as a random process. So this is what I've said here. So yeah, the question here is, could beta be a more stable process to capture and minimize the degeneracy over time? So going forward, this motivates SMC algorithms that can deal with a high-dimensional parameter space, and I talk about a static parameter space here. System shocks, so interventions which are going to drastically change what you see in your data, and the latest stochastic processes underlying both demographic and environmental stochasticity. Standard approach would be particle MCMC, but as those of you know familiar with these algorithms, that's going to sort of really damage your real-time capacity and take 2 months to run. One of our co-authors, Anglos, is a big fan of promoting SMC squared, but now we've got time to breathe. This is the time to start investigating these kind of algorithms. So the challenge going forward is to come up with a unifying approach that can combine Garen and Aldo's work and maybe some of the stuff that we've done to develop suitable algorithms that can be implemented in real time. Thank you.
Firstly, I thank the authors for both the paper for their excellent work and guiding us through this pandemic with providing real insights in real time to policymakers. And I think both the papers showed how difficult it is to estimate quantities in realistic models, and that is something I want to touch upon a little bit, especially on the second paper. So, kind of like we in our group, we have been working a lot to kind of move or translate from a ODE-based universe of kind of modeling a population system to a more stochastic universe, and we kind of envision these as like a Lego sort of way of composing with stochastic elements, and basically like we want to have all these stochastic elements, and I really like that the model discrepancy part was also kind of touched upon in the first paper as well. I think that's extremely important. And so obviously we want to get to this stochastic universe, but the real problem is we still do not really have scalable and real-time inference. And I think the paper that I'm commenting on, the second paper, has done really good work guiding us toward this universe where we want to go, hopefully. So currently in our COVID work, in collaboration with the previous speaker, we are kind of dealing with sort of partial stochastic systems where we have some sort of ODE-based model for the compartmental system, but then we want to kind of model some external perturbation using a kind of discrete time process. And so we have used so far Gaussian random work. We have also played with Ornstein-Ulmer process, and we are also trying to go to more time-varying volatility models. But something that is kind of important and challenging is how do you do inference with this? And when I say inference, I want to say inference of the process as well as the static parameters. And that's actually really challenging to do inference of all the unknown random variables here, because the process, the sample path of the process gets bigger and bigger, and inference becomes really challenging, and SMC is kind of the way to tackle these problems. And the particle MCMC method, which was published more than 10 years back, kind of was like real seminal work on how do we kind of do this joint inference. However, it is really difficult to kind of scale this to real world problems or real world models, because we have high dimensional systems for which to have good mixing of the MCMC, we want to use lots of particles, but then we do a hit by the computational bottleneck. And so it is difficult to actually take these methods from simpler systems to actually translate or scale them to complex models. And I want to touch upon kind of the other forgotten orthogonal direction that somehow is kind of not looked upon carefully. And especially there has been a lot of work on this direction as well. So that's basically using approximation of the model and approximations of the stochastic process. And that stochastic process can be the external stochasticity or the internal, basically the full system. And we kind of are, in our group, are looking into these sort of diffusion-based models and then approximating them. And these approximations that we are kind of inspired or thinking of, they are kind of motivated because we now have a lot of new tools that are available in recent years. So, for example, most importantly, automatic differentiation. Are we really exploiting these tools? And there have been so much work on deriving tractable approximations and methods to get gradients out of these approximations. And using these type of ideas, actually, there can be orthogonal directions or orthogonal research approaches to SMC. So you have a high dimensional system, but then you also have gradients for that system, and then use those gradients to kind of compose samplers on function spaces. And so this is kind of this is kind of an orthogonal approach that I think more work needs to be done. And we kind of did some initial exploration, kind of using a continuous time process to kind of move from a piecewise constant random walk. The piecewise constant is because it's too hard to infer a continuous process, and using approximation to diffusion processes. And the state-of-the-art approaches to do these models are particle MCMC, but I don't think, at least very soon, we are going to be able to scale these methods to real-world transmission processes. But we really have lots of new tools that have come up in last 5-6 years that let us go a long way with approximate stochastic processes and integrate them with SMC as well. So once again, I like to congratulate the authors for both the papers. Thank you.
Hello everyone, I'm Pedro. I'm currently doing a PhD in King's College London. I'm not working with COVID modeling anymore, but I did work on it while I was in Brazil, working for a company that was trying to give information to policymakers in a specific state of Brazil. We were using a variant of the Flaxman et al. Model, and we did run with the problem that the model was too slow to be able to use it in real time. And one of the things that we proposed to mitigate that was to use sequential updating. So using the posterior distribution of each model on, for example, a week, on the next week as the prior distribution, and that improved a lot of the runtime necessary on warm-up iterations for the Markov chain Monte Carlo model. Also, another issue we did have is that, unfortunately, in Brazil, we did not have reliable information. Sometimes deaths were updated 2 weeks after the death actually occurred. That had a great impact. We had to add that as a part of our model, so we had to model the sub-estimation of deaths and the sub-estimation of cases as well, to be able to try to kind of model these faults in our reporting system. And we also found that incorporating the infection data with some kind of estimates of how much the data was being underreported also contributed for the model to be able to be better at forecasting. And just to be clear, I was a data scientist. I'm not a statistician by trade, so I came to this with more of a focus on the machine learning perspective. So we tried seeing how well for example, the error, the absolute error, the mean absolute error of the predictions were matching along the weeks. And we had this information, like, this is the information we had at this week, and then this is the information we had at that week. I think that's pretty much it.
Hello, I'm Seth Flaxman. Thank you so much to the organizers and to the attendees and to the people who sent things in. We're so sad that Peter Diggle couldn't join us in person. We very much appreciated the comments, and I will be inviting my colleagues to address various bits of them, and then I will come in for other parts. Would you like to start, Neil?
Sure. So actually it was more in relation to the second paper, but I'll start with a general comment about the relationship between renewal equation models and compartmental models. I mean, fundamentally, the difference is whether you model the feedback process. Beyond that, I mean, mathematically, they are very closely related. Compartmental models, of course, tend to make assumptions about exponentially distributed waiting times, but you can map them directly onto another. So to come to Sylvia's comment about, I mean, we can get out, for instance, the numbers of people currently infected, numbers of people currently in hospital from a renewal equation approach. The second quick point I just wanted to make is that we've always had within Imperial Group a suite of models. So we do actually have a large-scale compartmental model which has been fitted to both infection prevalence, case, death, hospitalization data, very similar to the Norwegian model, which is a stochastic model fitted through particle MCMC. Very computationally intensive, but it is possible to do.
So, as we will have a considered response later, just touch on a few points. So, number one, the ascertainment ratio is so important, of course. And we have actually done several bits of work that do data synthesis on it. Axel's LTLA model that we use on the public base uses many different sources of data to get data synthesis between them. The exact approach that you've discussed in Nicholson, we have done in a branching process paper to show that you can use serological data, in our case the ONS, and case data to determine where the differences lie between the two of them. In terms of mediation, yeah, of course, it's really important if we could use social behavior, and as I stated, I think we need more social behavior data in that. What's interesting is the behavioral data actually follows the mobility data. So the behavioral data actually is sort of informed almost by the lockdown itself. You could conjecture that they all followed from that decision, and rather than people self-moving on that choice in the UK, but that's a hard one to call. On the topic of spatial aspects, of course, Peter knows very well that I appreciate the spatial statistics aspects a lot. The issue that we had was not that we didn't consider it, but that what we really need is flows of people, which means, you know, although contiguous regions between London and Manchester aren't close geographically, which is what you would get when using a traditional Gaussian process that you then put into a low Gaussian process, actually it's the mobility flows that are really complicated. And yes, unfortunately, Google Mobility did not give you this level of granularity spatially, but this is definitely important in the future, and Peter's 100% right. What do these RT estimates mean outside of the spatial context? That's a huge bias that we can't account for. Yes.
Okay. So there was a very important point made about data and code availability, and so I think it is worth giving ourselves credit, patting ourselves on the back, and lots of other people have done this as well. But the original report that all of this stemmed from, which was released March 30th, 2020, Imperial College report number 13, all of the code was available immediately on GitHub, and that meant that people in Brazil were able to reproduce it and apply it to their settings. And I think that that was very, very important for people around the world. It was very important for us in terms of getting immediate feedback about how can you make your model better. You know, the Stan development team immediately jumped in and said, here's how you can refactor your code so that it's a little bit more efficient. And those sorts of things were critically important for our work, and then I hope for other people's work.
Just to touch on your points, inference is so important. Updating the posterior, as you described, is extremely sensible and something that really should always be done, improving the prior evidence. And I think that's a very sensible approach. With regards to the issues in Brazil, I think we do cite your paper in a recent paper of ours, where we do Gaussian process nowcasting. Exactly this issue, that you have death data that takes time to manifest into the system. We use nowcasting to sort of predict where we are. So it's almost now becomes a three-stage approach, where you first need to nowcast to get the best estimate of deaths right now, from which you then build your mechanistic modeling. Now, in a perfect world, we propagate all the uncertainty, and that costs a lot, but as you just stated, you have a very elegant and standard approach, which we should all use rather than running the model again. And then finally, I think as a point of Neil, the sequential Monte Carlo is slow, but with enough implementations as has been done in the real-time modeling team in Imperial, it really did run real-time in SPIAM with our colleagues. So, ish, Daniela. Just about.
Just one more point about these ascertainment rates, these alphas in our model. One thing is, yes, you can. The gold standard probably would be to just include randomized surveys, if you have them, as part of the observations in your model. That would be the nicest thing to do. The other thing, in some settings, it didn't really matter whether you got them exactly right. If your main interest is your reproduction number, and you got them roughly right, it wasn't very important if you were off by a constant factor in your ascertainment rates. But that's, of course, making lots of assumptions, but at the end of the day, if you're just interested in how the reproduction number varies, you could get sometimes away with it of, well, being slightly not knowing what these values were.
Okay, so do we stop 2 more minutes? One more minute? Okay, so at the... I'll let you talk about that. So, indulging my self-citation, I think that here at the RSS, we are enamored with randomized surveys, and so I would just want to give a note of caution about that and promote a different paper that is from my student and from some other people. So we looked at 3 different randomized surveys, and we looked at vaccine uptake in the United States. And we found very, very, very large discrepancies between administrative data, so the Centers for Disease Control tracks how many vaccines are put into people's arms, and these 3 big surveys, one from the United States Census Bureau, so a very high quality survey, Oh, I see what the problem is. You can't find the notes. That's why everyone's having so many issues. Another survey from Facebook. So some people might be familiar with the Facebook, University of Maryland International Survey of Countries, Behaviors, Vaccine Uptake, COVID Cases. This is their US version with Carnegie Mellon. And then Axios, Ipsos. So this was a sort of standard pollster doing a survey. And if you look at the figures, which are somewhere here, you see very, very, very large discrepancies. And so this is not just to promote this paper, which I think is very well written and interesting, and you should read our paper, but also to give credit to the Office for National Statistics and react to different high-quality randomized surveys, which didn't always agree, and that was something that was very useful to have throughout the pandemic.
Yeah, finally, on the note of the residuals, very important. So there is one limitation with the two-step approach, which is that it becomes more difficult to propagate uncertainty. 100% right on that. The two-step approach is faster, but yeah, we don't propagate uncertainty. Now, in terms of discontinuities, one can account for this in the fixed effects to some degree, but that becomes a bit artificial. We have looked at latent factor approximations, actually, from your recommendation, which I think are more elegant but more heavyweight. I think on balance, the random walk process can, at least as a first order, encode some degree of roughness that perhaps higher order random walks or Gaussian processes with smooth kernels can't. So yes, it is an issue to have discontinuities in the data, especially around the time of lockdowns. But given prior knowledge of interventions happening at certain points and fixed effects like mobility that do capture this, in the best case, behavioral data that also captures this, for example, YouGov or Comix reflects behavioral data changes that show the discontinuities in the step functions. These step functions can be accounted for in the fixed effects such that the residuals would be perhaps slightly smoother. But of course, this is always a limitation, and I think our colleagues have an elegant solution with their split functions based on alpha.
Okay, thank you. Thank you very much. And Arnaldo and if you'd like to make a reply, please.
Okay, thanks very much for all the comments, questions. We will not be able to answer all of them, but we are looking forward to the written responses as well, so we can go more into details on this. But first, response to Sylvia. I was very happy that you mentioned uncertainty and then the difference between the APSM. This is certainly something that has been very important in the work, that we emphasize the uncertainty, and we actually also report that further on. So they take that into account when doing decisions. But at the same time, as also Sylvia mentioned, we are not fully taking into account all the uncertainties in that some of the parameters we have fixed. Although some of the parameters that we have made inference from external sources, we actually have put priors on taking into account uncertainty as well. But that should be done more systematically if we have had time to do that. You also mentioned conflicts, and Paul was also into that, and that certainly is a problem, both from a statistical point of view, but also computationally, and that if you get conflicts either between the data sources or to the model, then the sequential Monte Carlo methods or any Monte Carlo methods will struggle. When we were doing this on a national level, we didn't have that much problem with conflicts. We did have it in the beginning, as Paul also mentioned, but we mainly got problems with conflicts between the test data and the hospital data when we went down to the regional levels. Then we saw much more conflicts. And the way we solved that in those cases, although this is a bit outside this paper, it was to do tempering as well. But a little bit different in that we actually did have a fixed kind of tempering, using an approach also discussed in Milder and Dunson in a paper in JASA, where actually this tempering corresponds to some kind of robustness with respect to the models. In addition, we also, in order to take into account of shocks that could come in, we also have tried somewhat to use T-distributed noise instead of the Gaussian noise in order to account for such shocks. But we need to do more work on that to actually make it work properly. You had, as Sylvia also mentioned, we have this 24 days fixed lag smoothing in fonts, and that we do in order to produce, in some sense, the smoothed daily reproduction numbers for the whole time period. But in the end, we are mainly using 7 days fixed lag smoothing. So we always, when we report results, we do use the data we have up to that day, but then we go 1 week backwards and report the results there. We don't trust the last 7 days due to the large uncertainty. So that was mainly Sylvia. Do you take Peter?
Sylvia, you asked what is the generic lesson to draw for Bayesian inference. And everything went so fast, I think we didn't have time to understand anything yet, right? And it will take time. But I mentioned modularity, thinking of modules that stand alone and can be continuously used untouched while other things are changed. Then you mentioned, and Guy also now, conflict of interest that is changing over time between different data sources. That's an important issue for us. For example, when we predict hospitalization, we do not use testing, simply. It is better to predict hospitalization without testing than with. And so we need algorithms that decide what data to use automatically, right? And they will come. The main problem for us is the probability of being hospitalized given infection, which we try to model very carefully. We change it every month in all our models. We have decent data externally to estimate it, but the conflict is resolved by hand by looking to case hospitalization rates and see how it changes. So it's very made on Wednesday morning from 9 to 10 before we decide what do we say now about these results. The other point that you made is about the calibration variability, which I think is decent in our case. But it's surprising the little sensitivity analysis that we did. So we changed, for example, the probability of asymptomatic cases from 30% to 40% to 50%. We changed it to 80% to 10%. It's very robust, which also shows that parts of the model are in fact not so important, which is a bit sad. but so sensitivity. But the main point is all the uncertainties that we produce are not correct, right? But are they sufficiently correct for decision making? So at what level should we be able to estimate uncertainty so that uncertainty is useful for the decision making? And maybe we don't need to go beyond that. Peter Diggle mentioned space, the role of space, and here I'd like to say that the data have a given spatial resolution, which is somehow guiding everything else. The hospitals are there and they are in a place, and that's where the data come from. The mobile phone mobility is at a certain resolution. So in some sense, I think that in this case, I wouldn't see a big advantage of going to a continuous space model and then discretize it. But I see the generic point. The reproduction number is changing rapidly, and I think this has to do, as I mentioned before, with outbreaks. And Peter provocatively asks, but I mean, if it changes so rapidly, what sort of predictions are you doing, right? But we have to remember that the effect of the reproduction numbers changes is seen 2 weeks after in the hospitalization. So these 2 weeks saves us. And again, doing reproductions, doing estimations 1 week before is enough. And it's these 1 week time are important. We did not use death data at all because they are not. There's too much underreporting and too much informative missingness. Finally, I'd like to give a small comment on reproducibility and making software available, which I 100% support. But realistically, this is not going to happen. I mean, these softwares, these codes are extremely complicated. They are impossible I think, to be produced in a way that you download it, click it, and run it. This will not happen. So we have to be a bit honest here and say that there's not going to happen. There's a lot of work behind these algorithms that is carried and made by tens and tens of people, and it is like this. So not every problem can be packed into an R package, and maybe these are problems that cannot be packed into an R package. Thank you.
Do you have more? Yes. Yeah. Just to correct a little bit, we have the code out, so we can actually reproduce it. So it is on the Git available, and there is a reference on in the paper. A few more points. Sylvia mentioned block updating. We are in some sense doing it since we are only running it every week, but we could do it even on longer horizons. Paul was discussing several issues related to more efficient SMC algorithms, which certainly would be beneficial here. But and if we had time, we would have liked to use it. And this is really something I would like to do. So I would really like to discuss further with you about that. Model comparison was mentioned. Sequential Monte Carlo is in some sense quite fit to that, given that it gives unbiased estimates on the marginal likelihoods. And we did somewhat use it for selecting between models for the reproduction numbers, but it relies quite a lot on the actual model is used, so other tools could also be useful. For instance, what used in other papers, like looking at these p-values and so on.